It's pretty incredible.
Check my option side rates.
100%. You guys can hear me? Okay, cool. In the global public, right? So yeah, talking about really bad strokes today. Sabam PGY2. Actually seen like quite a few of these for whatever reason since I've started here. Maybe like 10 or 15 of these. And then I think a lot of people have also told me, like with the COVID, like a lot of patients coming with large strokes as well. And so, I mean, everything is kind of relevant this time. So we're going to talk about kind of three main things. Here's my objectives. I'll define kind of the syndrome and the clinical progression. And then we'll sort of talk about ways to risk stratify like who might develop like pretty bad cerebral swelling. Briefly touch base on just kind of hyperosmolar therapies for medical management. And then just kind of like a brief sort of summary of what I found from like looking at the literature with respect to like reperfusion actually. And then lastly, talk about the role of neurosurgery with these strokes. And that's actually like the definitive treatment here because our medical management is pretty poor. So we'll start with some basic neuroanatomy. MCA supplies a pretty large territory of your brain, pretty much from like your anterolateral frontal lobe all the way to your parietal lobe. And, you know, the internal carotid, so MCA branches off your internal carotid artery right here. And then mostly like these strokes are the result of like these large occlusions to like M1, which is this big trunk here, and then M2. And M2 kind of divides into like the anterior branch up here, which supplies your Broca's area, and then the posterior branch here, which supplies Wernicke's area. And then M3 and M4 kind of more like cortical, more distal, but it's really M1 and M2 that are the main culprits, and you see a pretty large occlusion right here. And essentially, these patients are coming in right with like pretty dense like deficits. So, you know, facial droop, significant hemiplegia, hemisensory loss, gaze deviation to like the side of the lesion, and then depending on whether it's the dominant hemisphere or not, you get like global aphasia, mostly in like your left MCA strokes, and then if it's like the right side, you get neglect syndromes of varying degrees. And so, like I said before, it's primarily M1 and M2, but you also need pretty poor collaterals so that when you occlude the MCA, the ICA, or one of these branches, you get this large territory of infarction. So the general kind of mechanism of death is you get this very large territory of infarction, which promotes a lot of cytotoxic swelling. It leads to vasogenic edema, and then it ultimately progresses to herniation and death. About 15% of these large MCA strokes develop malignant swelling. And the timeline, typically it's really important to note that within the first 24 to 72 hours where you see this really bad like mass effect in cerebral swelling. And these patients, you know, they get admitted to the ICU for herniation watch, or they go to like a neuro step down for like close neuro checks. But the typical course is day 2, day 5 is when they end up dying, basically. And the mortality is pretty high, even with like maximal medical management, approaching 80%. So is there a way for us to be a little bit proactive in identifying these patients a little bit early? And so we'll talk about some like factors maybe that might predict swelling. Obviously, you know, people who have really bad hypertension, other sort of like vascular risk factors, they don't do as well with these large strokes. And nothing is super precise, right? We can't predict with like 90+% success rate that, you know, this patient is going to go on and have like really bad swelling. But a lot of the meta-analyses seem to settle on these kind of 4 indicators or factors. In terms of age, your older patients actually have larger infarct cores, but because, you know, they have a decent amount of cerebral atrophy, they're protected. And so your younger patients have less buffer for the edema and swelling that leads to like pretty rapid clinical deterioration, essentially. It's fairly intuitive that, you know, having like a higher stroke score reflects like a more severe deficit, leads to like a larger infarct volume. But what's interesting is that there's a 5-point difference between your left and right sided infarcts. And if you look at the actual like NHS's scoring rubric, you realize that, you know, the system itself kind of biases left hemispheric assessment. So level of consciousness questions, level of consciousness commands, language assessment versus only like looking for neglect as like predominantly right hemisphere dysfunction. So that's the reason why you get this like 5-point differential, which actually you see it in a lot of different studies that it's confirmed. So like right-sided MCA, it's like a 17, somewhat equivalent to like a 22, like broad strokes. In terms of the third bullet point, obviously, the decline in the level of consciousness is probably the most specific sign, really, of active herniation. These people aren't really doing very well, but it's, a rapid fulminant course. And then lastly, having a super large infarct area, I think 50% and more associated with like a sensitivity and specificity in the high 90s, essentially, people progressing to pretty bad swelling. So we're kind of mindful of like these risk factors, but these patients come in, right, and you get a non-contact CT. I think like it's pretty easy to just be like, okay, stroke, get the CAT scan, is it a bleed or not, and let neuro kind of like follow things up. But I think we can definitely do more and kind of go beyond this like bleed or no bleed paradigm, because there are a lot of different signs you can actually look for, because these are pretty large territory infarctions, and so us being able to like identify some of these things quickly will actually help expedite the management and the disposition of these patients appropriately. This first bullet point here with like the hypodensity on the non-confident 6 hours, involving a third or more of the MCA. So this is actually a contraindication for TPA, so keep that in mind. And then these other two signs, even though there's like wide inter-observer reliability on CAT scan findings, they tend to kind of come up over and over again in the literature as like a reference. And so it's helpful for us to kind of put this in our armamentarium as well. So we'll start with something fairly obvious. So areas of hypoattenuation. CAT scans are obviously have pretty poor sensitivity in the setting of all comers with stroke. But since these are pretty large occlusions, essentially, you can start seeing irreversible infarction within the first 2 hours after the onset of stroke symptoms. And these areas of hypoattenuation, essentially, it's a lot of intracellular edema. This is irreversible damage, basically. You can't tell if there's a penumbra with a non-contact CT, but, this signifies a lot of badness that's going to happen. And so what's interesting is that these two are actually patients that I've taken care of here. This person was someone we saw in CCT about 2 weeks ago, coming with like pretty significant left side deficits. You even see like an element of like hemorrhagic conversion here. There's a little bit of midline shift. He's still in the ICU. This person here was, this was my first patient at downstate on like my intern like shadow shift. Shout out to Jan. This person came in as a cardiac arrest with ROSC. Her last Noel was about 25, 26 hours. And so, yeah, not very good. Yeah, she passed away, terminal extubation in the ER, actually. This is a pretty obligatory slide to talk about. Actually, you can have a dense ACA, a dense PCA, a dense basilar artery sign. The density is just referring to like the high contrast and like the MCA here specifically, and that it's just like it's brighter than the adjacent brain tissue and the other sort of arterial areas surrounding. And there's pretty significant discussion in the literature about whether this has any kind of diagnostic utility or not. Some people say, no, there's no correlation with outcomes, but there's a lot of data that seems to imply that, seeing a dense MCA sign on your non-contact CT, it's poor prognosis in terms of like future neurological like functioning. It's poor, has a poor prognosis in terms of the patient might develop malignant swelling earlier and faster. And even some people say that the patients with this sign, they might not really respond well to IVTPA. It might even just be like a thrombus in situ. And since it's M1 here, those patients do a little bit better with thrombectomy, actually. So yeah, pretty high specificity for seeing this and correlating with like some kind of M1 or M2 occlusion. Just be mindful of like the few false positives that do exist. So if the patient got IV contrast, say like a couple days ago for whatever reason, you might see this like pseudo dense sign. Otherwise, people with like really high hematocrits for whatever reason, like they kind of have this pop up. And then lastly, if you have significant calcification in the vessels, but that would tend to be bilateral, and you'd be able to kind of like correlate with the actual like presentation as well. And this is a little more subtle, but it's referring to kind of this loss of the gray-white differentiation in the insular cortex. So the yellow arrows here, the blue arrows, and like the next two CAT scans. And the insula is very susceptible to ischemia just because it's kind of furthest from the collateral flow. And so you end up seeing this in a fair number of large MCA strokes, actually. This patient in the middle was another patient we saw 2 weeks ago, who she came in with like a stroke score of like 15, essentially. And she ended up getting TPA. She's still in the hospital, but she's doing fairly well. And then this one it's actually a pretty good lesson. Another patient in downstate last year in December. Came as like a stroke note, pretty dense like neurodeficits. Went to head CT, had some issue with like IV access, so they didn't get like a AC. So they just came back later. We talked to the radiologist who actually said this was a totally normal CAT scan. The neuro resident who was there was actually like, looks kind of off. Like this part looks a little bit of face. Like let's kind of expedite the CTA. So we ended up transferring this patient to MIMO. They got thrombectomy and did very well. So I think this is definitely within the scope of our practice to kind of look at these CAT scans and kind of add this to our ability to like, see these signs, because then we can kind of treat these patients better. So, talk about how to risk stratify people, look for early findings, so how do we treat patients, right? Especially when they're best, you're eating this like kind of terrible sandwich. There's no good grade 1 evidence for any therapeutics really for these really bad strokes. We're following expert consensus, a lot of observational data. And then if you look at the thrombolytic data, it's very mixed in and of itself too, which is, I think, kind of telling as well. I think we'll have like a talk later that goes over different kind of therapeutics in terms of like blood pressure control, that kind of stuff. But a lot of this stuff is still just kind of like expert consensus and just there's no good data supporting it. We tend to give hyperosmolar agents, so mannitol and hypertonic saline, especially these patients if they're starting to like show signs of good changing neuroexam, they're decompensating, they're herniating, right? And so we're treating symptomatic edema with mass effect with both of these agents. And the idea is that both mannitol and hypertonic saline, they reduce the ICP by creating an osmotic gradient to draw the fluid out of the cerebral space. They both tend to increase the cerebral blood flow, and this helps to reperfuse like the penumbra that can possibly be salvageable. And in addition, mannitol also has a pretty potent effect as a diuretic. People tend to agree upon the fact that there's no role for prophylactic use of these agents, and so if the patient's neuroexam is kind of stable, they're mentating as well as they can be. Don't give these medicines like empirically off the bat. Unfortunately, after that, like it's pretty unclear if there's any kind of actual benefit. So there've been many RCTs that show that these drugs don't really improve mortality or have positive functional outcomes for patients, whether it's like in the acute or like the 3 or 6 month range. And there are head-to-head RCTs comparing mannitol and hypertonic saline, but they're limited by the fact that it's very heterogeneous. A lot of institutions have different protocols, different dosing regimens. But there seems to be a signal that indicates that saline might be more effective in reducing the ICP and also for like a longer duration of time. There's lower rates of causing acute renal failure, causing pulmonary edema. But once again, the magnitude of these differences and what that means in terms of patient outcomes is still up to be determined essentially. In terms of like sort of the adverse effects, I think we get this a lot with giving hypertonic saline, where it's like an institutional policy that you need a central line to administer it. Especially for 3%, there's really like no evidence saying that you need a central line. So it's kind of pretty poorly defined. I think people were kind of basing it off these studies that looked at TPN being administered through the peripheral IV, and that's like really, really high osmolarity for like 2 weeks, and that causing necrosis. But that's not really applicable to the situation here. So just keep that in mind. But I think a lot of this is going to be determined based on like the institutional culture, like what agents are available and stuff. But you can kind of like decide which agents to give to patients based on like what their comorbidities are.
Don't give mannitol to dialysis patients.
Yes.
They get hyperkidney.
Yeah.
Really hyperkidney.
Yeah.
And it's not clear for real dialysis.
Another thing you can do is if you're getting pushbacks from, like a lot of the time it's nursing and they don't want to give the 3% saline.
Yeah.
What you can do is you can just give 2 amps of
Bicarb.
Yeah. Yeah. And it's basically the osmolarity, it's even a little higher than 3%.
It's like 7% or 8%. Yeah.
So it's the same thing. It's hyperosmolar therapy.
Fool the nurses.
Yeah, well, it's kind of what it is basically. But yeah, so you can just do that.
Yeah.
People, it's pretty cool.
Yeah, Trevor's pretty cool move, being very clever, was to give 2 amps of bicarb. Essentially, it's because it's very hypertonic. It's almost like 7%, 8%.
Yeah.
So yeah, so if you're in a pinch, you can just do that and kind of do the initial treatment that way.
Assuming the patient is dying.
Yes, yes. It's not just for fun. I mean, it could be. I don't know. Yeah, you could spend an entire lecture series talking about TPA and revascularization. I think for our purposes here, know the absolute contraindications, but you know, if these patients come in like within the window, they're gonna get TPA because that's sort of the standard of care, whether you like it or not. What's interesting though is that we know these patients right now that we can kind of identify certain like more subtle findings. You see a dense MCA sign, you see like effacement of like the gray white matter, you know, all these different things, you know, you can kind of like risk stratify them based on their characteristics. These patients with really dense like MCA strokes, like they're higher risk of converting to, you know, to like a hemorrhagic conversion at baseline, right? Without any kind of thrombolysis. You know, they're higher risk of having this like malignant transformation with like worsening brain edema at baseline as well. So just be mindful that, you know, thrombolysis, even though some studies seem to indicate that there might be a benefit, that reperfusion is not a benign thing in and of itself. And so these people will be boarding your ER, staying in your ER for a while, right? And so just be ready to manage any kind of complications that might arise from this. I think what's interesting is that the thrombolytic data, you know, it's unclear if you can actually generalize like those findings to like this cohort of stroke patients, because a lot of the canonical like studies, NINS, ECAS, ECAS3, they tend to exclude like these high NIHSS stroke patients from like the treatment arms. And so you can't really generalize that. The thrombectomy data is actually a little more promising. They tend to include like larger stroke patients. But once again, and I think you also realize just like how many patients does Dr. Bell actually take to angio? Like not that many, right? And I think the reason is because for these like large strokes, most of these patients, you know, they're unlikely to have like a salvable penumbra, essentially. They have pretty poor collateral flow, and so the risks of actually intervention, you know, going ahead with the intervention is actually higher in that situation. And so it's really only a select group of patients who are appropriate and who actually end up benefiting from like therapy. It's helpful to kind of look at CT perfusion or MRI, and Dr. Stinner he sent out like a pretty good article recently, I think in Annals, right? Yeah. It's a good read because this is becoming more and more like a part of like the general stroke workup. But these imaging modalities are helpful because they help us determine, you know, how large is the infarct? Is there any kind of salvageable penumbra? Is there like a mismatch that can be like reversed essentially with intervention? And our neurology colleagues, the interventional colleagues, they use this ASPECT score. It stands for the Alberta Stroke Program Early CT score. It's like a formalized method of estimating like, you know, like the infarction territory in the region. The main takeaway I think is if you have a score of 7 or less, some papers say 6 or less, then it predicts like patients having poor functional outcomes, both like in like the week and in 3 months, 6 months out. But also if these patients receive any kind of thrombolytic therapy, they're at higher risk of having like symptomatic hemorrhage. That's kind of pretty bad. So pretty much like a downer talk, but you know, we have pretty few options for these patients in terms of how we can treat them. It turns out that the only intervention that has a proven mortality benefit really is kind of controversial, but it's, you know, having neurosurgery come and just decompress the skull. This is sort of based on these 3 major trials out of Europe in the late 2000s, Decimal, Hamlet, and Destiny. You know, the numbers that they've enrolled are kind of small, but it's difficult to sort of study this in general. But all 3 of these trials individually showed a pretty significant mortality benefit in the surgical arms when you go ahead with the intervention within less than 48 hours from onset of symptoms. The trials by themselves individually did not actually show like a favorable functional outcome, but the pooled analysis tended to show that there's a pretty significant sort of difference in like the modified Rankin score. Essentially, the modified Rankin score is like used as a way to kind of just decide like what the functional outcome is. And so in brief, like a score of 0 to 3, implies like a good outcome, where 3 basically means that your patient is able to take care of most of their needs independently. They still need some help, but they're fairly functional. And then 4 to 6 is like the poor outcome range, where 4 is like moderate disability, 5 is like severe disability, and 6 is death, essentially. They try to like see if maybe patients above the age of 60 might benefit too, but this study showed that you have pretty significant improvement in mortality rates, but all these patients pretty much are left like severely debilitated.
This is for prophylactic craniotomy?
No, this is for like doing the surgery with patients who are kind of like developing signs of herniation, but it's within like the 48-hour time period, basically. Yeah. No one really advocates for doing these surgeries like prophylactically, just because we don't really have good like indicators of.
There's some places that do that for large.
Yeah. Yeah.
It sounds like it's before they're actively herniated or something, right?
It's kind of mixed, because the studies themselves looked at patients who have large like malignant strokes, and they're at some point either the scans themselves demonstrate like worsening edema, or the clinical status is starting to deteriorate. So that's when they end up kind of taking these patients to surgery. There are some people who advocate for intervention, like even like early on, like say you get the CT scan, you see like a 50% like MCA kind of like hypoattenuation, or like, these patients end up getting like MRIs or perfusion studies, anyways, because you want to kind of see if they might be a thrombectomy candidate. So you end up actually seeing like a pretty large infarct report, right? But it seems like no one's really advocating to like just take them immediately from the time they come to the ER. And so I think the main controversy here is that, people feel like, can you really consider it a good outcome if these patients live, but they're left with like significant like cognitive and functional debilitation? But I think that's kind of like where you have to have a pretty good goals of care conversation and see what the expectations are for patients and family. So I think people have very different sort of understanding of what they would be okay with post-surgery if they end up doing it. And I think our role in the ER specifically, like, I think if we're able to see like these large infarcts on the CAT scan, you go ahead and get the imaging to see if like they're a thrombectomy candidate or not, and you end up seeing like large areas of infarct. You see like not much like salvageable penumbra, and you kind of start the goals of care conversation. I think it's totally appropriate to call neurosurgery for these patients, just so that they're on board early and they can have this conversation and kind of really flesh out like what the goals of care are, to see if like the patients are appropriate candidates or not. Some people even argue that patients above the age of 60, if they're otherwise pretty healthy, like maybe see if they would want surgery or not, see if the family thinks that it's appropriate or not. The data is obviously like, limited, but I think it's a thing to consider, like the patient's kind of wishes here. So in summary, it's pretty high morbidity and mortality condition. Be mindful of like the time frame within which you get the progression of malignant edema. Let's go beyond just like looking for a bleed, look for these other signs too, because you can definitely impact patient care this way. You can give hypertonic saline as like a salvage, and I think it's important to kind of read like the broader sort of like TPA and thrombectomy literature just to get a sense of what we're doing for these patients, because you'd be surprised what the literature actually shows, and then the role of like early neurosurgical intervention for these patients too. This actually saves people's lives. Then it's like a broader question of like what you think an appropriate outcome is, basically. My references, and then people want to think.
My experience with using hyperosmolar therapy is that it only really seems to work when you can do something definitive and you use it to buy time, in my experience. For example, when you have an epidural or subdural that's causing herniation, and then you can use those. And I've always used mannitol because has been around longer, but to buy you that time so then you can get a neurosurgeon to take out the clot. Other than that, I haven't been impressed with using hyperosmolar therapy. They seem to rebound after a while when I've seen it used when you can't do something definitive.
I just wanted to make a couple comments. First of all, since Dr. G didn't say it, I'll say it. That was a really great lecture. I think this is extremely important for most of the reasons that Sivam already said. If you treat stroke like me, your main objective is to look for reasons not to give TPA. And that becomes really, really important when you don't have a neurologist in-house, and probably important anyway when you have to with the neurologist because they want to give TPA. The majority of EDs in the country, you're going to be the person making this decision. And you're going to have a radiologist who's reading from home and probably won't be a neuroradiologist. So I think something that we have the benefit of is the patient in front of us. And when you see enough of these, you'll develop kind of a heuristic of what they look like. It's usually the patient that comes in and you're like, this guy has a bleed. And if he doesn't have a bleed, he probably has a huge MCA stroke. So then you should start looking for signs of that, or maybe delaying giving TPA and potentially getting a perfusion scan or something like that, doing that extra test. Because as Sivam already said, this is going to cause harm. The other thing to think about when you're working in a place that maybe you don't have all the services at your fingertips is that maybe you're going to have to make that decision to get this person out of your ER. That either endovascular site or a place that has neurosurgery, or that a place that has a neuro ICU. So the decisions that you make in the ED, even though that it may not be affecting the patient right there in front of you, could really determine what happens to these patients. So I think it's extremely important to know this and to be able to look beyond kind of what we're, bleed versus non-bleed that Sivam said. Even if it's just stopping for a second and saying, this is not just a small stroke, this is something that may be very significant. So just, again, really great lecture. Thank you. Any other comments?